Hey guys, Marshall here with PhysioU. I'm here with Chris and Cam, two DPT students, and we're at the teaching table where we try to bring the classroom to the clinic. Today we're going to talk about the irritable patient. Right, so it's often difficult when the patient comes in and you're like, I don't know where to start, so I'm just going to do everything, and we've kind of been taught like, that's not good, right? Limit what you test, but you don't know what to treat then. So it's kind of this, it's messy and it's hard. It is hard, and I think when we talk about it, the first thing is maybe PT isn't the best place for them, right? And that doesn't necessarily mean that it's a red flag they have cancer, right? It just means maybe there's another department, whether it's physical medicine or orthopedics or some type of pharmacological stuff that is more beneficial at this time, right? If the patient is unable to take a step at all, walk at all, do anything, just laying there, it's a 10 out of 10. Maybe physical therapy isn't the best place at this time. Maybe physical therapy is a place, but they can also be doing something in conjunction. If it's more of just a persistent pain and going on a while, maybe they need to go see social medicine. If it's more of a very acute tissue-sourced chemical component inflammation, maybe they need an injection or a prednisone pack or something. So I think that's kind of the first idea is, do I even continue with my exam? Right? So let's say it is, right? It is, they are appropriate for PT. The big thing that changes is I don't need to do provocative tests at this point. Right? I don't need to try to prove what that tissue source is. I may use a lot of the subjective to kind of get a good idea of what I think my hypothesis is. So maybe I ask a couple more questions knowing I'm not going to do objective tests. So that will help me lead to my hypothesis. And then all of a sudden I start doing things that I think will decrease their pain. So it's kind of like a test, but it's already trying to treat. So my first test may be a position of comfort. If I lay you on your back and put pillows under your knee, does that make you a little better? Oh yeah, it feels instead of 10 to 9. Well, if you go to hook line or triple flexion or even knees to chest, what happens? Oh, that brings down to a 3. That test of does knees to chest, we're going to work on that. Just hang out there for 20 to 30 seconds. So it becomes this intertwined of I'm treating and testing kind of at the same time, but they're not provocative tests. It's positions of comfort to decrease symptoms. I'm correcting things. All right, let's take some questions.
So my first question would be, no experience at all. You're a student going into the clinic. What are the top red flags you're thinking of to see if this patient is appropriate for PT?
Good question, right? So sometimes the irritable patient is because of a tissue damage that's not appropriate for PT. So I think that depends on each body region. So if we're thinking more cervical spine, we have our D's and our N's and the nystagmus and all that stuff. Like I want to clear those out. If there's like a car accident or stuff like that, traumas, do they fit the clinical prediction rules that say you need film, right? Do you have a fracture? Same thing for like the knee or the ankle. We have like auto rules to say, hey, do you fit the idea where you need films? And if they've had x-rays and they're negative, I can kind of rule that out. If it's more like thoracic pain or something, I may ask questions about food intake or sleeping. If it's more lower back stuff, maybe I'm asking about bowel and bladder. So I think there's not like one red flag question I ask. It's more of based on this patient's story, what could it be? If it's a fracture, I know what I can ask for. If it's cervical myelopathy, I know what I can try to ask for. If it's VBI, so you kind of have certain things based on the bipolar. So that's a good question.
And also going out to the clinic and having these patients who are very irritable. How do we kind of talk these patients down? What is the type of conversation we want to have with them to maybe reduce their fear a little bit?
Good question. I think it starts by putting them in a position that's not very painful. Yeah. Right? So if I'm going to sit here and we're going to talk for 10 minutes and you're very uncomfortable in sitting, but you're more comfortable laying on your stomach, right? I'm going to have you lay on your stomach, I'm going to sit on the floor next to you, and we're going to have a conversation that way. If you do significant, I think it's an acute inflammatory problem, right? I may have you lay and I'll put ice on you, right? Modalities are very helpful in the irritable acute patients, right? It helps just calm down tissue, right? We're trying to just calm down tissue. So I think that's how you start it, is just don't even try to have that conversation in a very painful position, because they're going to be moving, twitching, and they're not going to be listening. They're going to be too focused about their pain. On the other side, once we get them there, right, we need to start talking a little bit about maybe the kind of explain pain model, Start to use the idea that pain kind of is protective. Right? Pain is like our danger alarm system telling us, pay attention. Right? If it's an acute injury, it's doing what it's supposed to do. It's telling you, don't use that limb, don't use that body region. Right? If it's more persistent, it's been there for a long time. Right? We can say, hey, it's protecting you, but how can we have it protect you less? How can we start to turn down that danger alarm? So I think that kind of depends on where they are. But regardless of where they are, acute, chronic, pain is pain. It doesn't feel good. And we can make patients' pain experience better by reducing fears. So what do you think some of the most common things we can say to patients that help reduce fears? Pain is normal, right? Pain is normal. Pain will get better, right? You'll get better, right? Just hearing that, patients already start to understand, like, oh, they're not just trying to, they don't think I'm lying, or they don't know what they're going to do. It's like, oh no, we'll get this together. Right? Yeah, I think it's a good question, and it's tough. Yeah. Well, you guys have another question?
We're good. Thank you.
Yeah. Okay. I think one of the key things I like to kind of tell the students and interns that come to the clinic is, like, for that eval or whatever visit you're on, right? It's not about trying to fix them there, right? It's not about, you're not going to, right? If they're irritable, it's how do I help them in this moment a little bit to where they come back and we can kind of progress, right? So an extra couple of days of tissue healing, a couple of days of pain management, right? A couple of days of modalities. When they come back, then you can kind of do more. You don't need to try to test everything looking for that hanging carrot that's going to be like, this will help them. Just be okay with, right, kind of survive the battle, win the war with these patients, right? I want to think, one of the other things I want to talk about is education. When we educate patients, they may not know that they're making their symptoms worse, right? So this idea of education to decrease tissue stresses, right? So they may not know that when they sit with their leg crossed underneath and their hips just on fire, they don't realize that, oh, you're in max external rotation. That's not a open position. Right? You guys are students. You understand, right, anatomy and stuff. So just educating them on things that they do that they don't even realize are part of the problem, to just start to let the tissue heal, right? Let the tissue heal. Yeah, and I think that kind of covers it for irritable patients. Just less is more, right? All right, thanks for joining PhysioU from classroom to the clinic, and take a look at PhysioU.com and our social media stuff. Thanks, guys.